range of upcoming educational events, and also to view some of our online resources from previous events. Just to let everyone know that this webinar is being recorded, and we will be adding this to our website for people to view at a later date. Participants may ask questions. They can do so by typing into the chat facility at the lower right-hand side of their screens. Our guest speaker today, he certainly needs no introduction. Professor David Moher is a senior scientist in the Clinical Epidemiology Programme at the Ottawa Hospital Research Institute, and he is also an associate professor at the Department of Epidemiology and Community Medicine in the University of Ottawa, where he holds a university research chair. Professor Moher spearheaded the development of several reporting guidelines, including CONSORT, PRISMA and PRISMA-P. David, we're delighted to welcome you to today's session. I'll now pass over the controls to you so you can get started. I'll just bring up your slides now.
Thank you very much, Sandra, and it's a real pleasure to be able to participate in this effort, and I'm really pleased. I thought what I should do first is declare some competing interests. As Sandra mentioned, I was involved in spearheading the development of CONSORT and PRISMA, and I have been involved in the development of SPIRIT, all of which I'm going to talk about. So I thought you should know beforehand what my competing interests might be. I have been involved in lots of other reporting guideline developments, and I am a member of the Equator Network steering group. I should say that I grew up in Ireland, so it's really fun to be able to give a little tiny bit back. But before I left Ireland, I purchased a little plot of land that you might be all familiar with. But now, moving to something a little bit more serious, Drummond René has said that the whole of medicine depends on the transparent reporting of clinical trials. And that's a pretty serious statement. And I think Drummond is probably very well positioned to say that, because he was the deputy editor for the Journal of the American Medical Association, JAMA, for many years, and really was incredibly involved in trying to get reporting guidelines, initially CONSORT, going. So what I'm going to try to talk about today is what do we know about the publication record? I'm then going to talk about reporting guidelines. I'm going to talk about CONSORT and other related guidelines, PRISMA, and also going to talk about whether reporting guidelines have their intended effect. Namely, do they actually improve the completeness of reporting? And then I'm just going to touch upon issues of endorsement and implementation of reporting guidelines. So without wasting any of your time, I thought I would start with one question. Sorry, there's someone tapping quite hard on their keyboard. If they could go on mute, that would be a little easier. Thank you. So the way I like to begin these talks is sort of talk about what I think are certain broad principles which we should all be in agreement with. And one is that research reports should be truthful and should not intentionally mislead readers. And the International Committee of Medical Journal Editors have indicated that in return for the altruism and trust that make clinical research possible, the research enterprise has an obligation to conduct research ethically and to report it honestly. And I think that's a really important point. What I would add is that it's not really about clinical research, it's about all research. So it's clinical and preclinical and everything else in between. So the second broad principle that I think is really important is that research reports must be useful to readers. And if they're not useful for readers, then we have a serious problem. And I hope that all of us would agree that it's important that reports are truthful, honest, and useful to readers. And from that, I'm going to now sort of move forward and sort of talk a little bit about the different types of problems we see in poor reporting. And certainly one of them, it's sort of best to think about this as a taxonomy. So the non-reporting or delayed reporting of whole studies, which is still a problem. Chapman recently reported in the BMJ on a sample of protocols that they followed forward in time for a number of years. And what they reported is that 1 in 5 surgical randomized trials are discontinued early, and 1 in 3 completed trials remains unpublished at least 5 to 6 years after the trial. So this is a problem, and it's not a problem of yesterday, it's a problem of today. So these are, this is a sort of a cohort that he looked at quite recently. Now, of course, that's wasteful, and it's wasteful to researchers and to their academic institutions. And it's also wasteful to funders who actually may have provided the dollars to facilitate doing these types of studies. And as taxpayers, certainly in Canada, most research is publicly funded, so we're, as taxpayers, paying into that system. And so it's obviously very wasteful if a third of trials are not published several years after completion. And it's all obviously quite wasteful for patients who need or want to make decisions about their care. And I wanted to read a quote from a patient. Firstly, that as a patient, I felt even more strongly about what I've been fighting for throughout my career. Research results should be easily accessible to people who need to make decisions about their own health. And this patient goes on to say, why was I forced to make my decision, my health decision, knowing that information was somewhere but not available? And that's a friend of mine, which is on the right in the red t-shirt, Alessandro Liberati, who unfortunately passed away a few years ago. He had myeloma and wrote some very powerful articles about the unavailability of information, of knowledge, in terms of him making decisions. So it's not an abstract issue. It really is an issue that actually affects patient decision making. Now, if we move in terms of the other types of reporting problems, I'm not going to mention them all, but I think if we look at sort of selective reporting, I think we see, again, some issues. Approximately a decade ago, Onwin Chan looked at the Canadian Institutes of Health Research and trials that they fund. And so the Canadian Institutes of Health Research is Canada's sort of prestige funding agency. It spends close to $1 billion a year on funding research. And what he found is that when he looked at a cohort of trial protocols and compared them to their subsequent publications, he found that more than 1 in 3, the outcomes differed. These are not just outcomes; these are primary outcomes that differed between the protocols and the publications. And some might argue, okay, well that's a decade ago, and no doubt things have improved considerably. And if you look at these researchers, recently published in the Faculty of 1000 research, and they essentially what they did is they sucked up all of the randomized trial protocols that are registered in clinicaltrials.gov, almost 90,000. And even a decade later, in 2014, what they find is a remarkably similar result to what Chan found a decade earlier. So we have approximately 1 in 3 primary outcomes are actually changing the protocol and the subsequent public. So we see that we have really considerable problems. And these problems really have a profound impact on sort of patient care, what gets published, and really it sort of begs the question: how can we change the situation? So here is a paper, again, recently published in the Lancet. It's one paper in a series of 5 papers about increasing value and reducing waste in biomedical research, and it sort of covers off both clinical and preclinical. And I think this paper is a nice paper because it summarizes all of the problems that we see in the published record, not simply the few that I've mentioned. And I would encourage folks to be able to go over and read that. So here's just some examples from Paul Glasio's paper. And so if you look at the abstract of trials that people have looked at, they found that actually the effect size and confidence interval is missing from abstracts. And given that abstracts might be the only part of an article that many clinicians read, it's really unfortunate that such important information is actually missing. And he goes on to show that right across the what we call the IMRAD, the introduction, the methods, results, and discussion, there seems to be a considerable problem in the published record. And this is a series that can be, you can get it from researchwaste.net. You can get it as an open, as a series of open access articles from that website. And in the articles, there are really sort of 5 stages in which there appears to be waste in the system. And we're down here at the reporting end. It is sort of really at the tail end of things. And obviously, we would like to improve things upstream. And I think that's why it's really useful to sort of look at this article from that perspective. So you have poor reporting of primary research. Again, this doesn't really matter if it's clinical or a basic science research. That poor reporting of primary research, those articles are included in systematic reviews. In the clinical domain, they're often the foundation block for developing clinical practice guidelines, and obviously those directly impact on patient care. So poor reporting is sort of not an esoteric issue. It's not a small issue. It's not an issue that will go away. It's not an issue that we can simply bury our head in the sand and hope things will improve. It's a problem that impinges upon patient care. And so we really need to do something about that. Most of the examples I use are examples from the clinical domain. I'm a clinical epidemiologist. I don't have a particular strong knowledge of what's going on in the basic science world. But I do want to sort of give a shout out to the basic science world and to the animal world, because inadequate reporting exists right across the spectrum. And here's one example from Carol Kilkenny, showing that the reporting of research in the animal world is similarly problematic. And I also have an important slide here, is that the NIH, which has a large budget of about $4 billion a year, they recently, Francis Collins and Lawrence Tabak are the director and deputy director, respectively, of the NIH. And they've written a very telling story about problems of reproducibility of basic science at the NIH. And it is such a problem, they're having to set up an office. So again, my message to everybody is that inadequate reporting cuts across the spectrum of research that we do. It's not a problem simply of clinical trialists. It's not a problem of people who do case control studies. It's a problem right across the board of people who do all types of research, geneticists, basic scientists, and clinical scientists. I'm now going to talk about what might be at least one solution to improve the published record, and that is reporting guidelines. And reporting guidelines are essentially, they're checklists, and they provide authors with a minimum set of items that need to be addressed when reporting a study. And I do want to emphasize it's a minimum set. Just because it's not in a checklist doesn't mean authors shouldn't report upon it. And reporting guidelines provide explicit text to guide authors in what to include in the type of research that they're reporting. And a consensus process, consensus process really is an important part of developing a reporting guideline, as typically is the development of an explanatory document, which gives examples of good reporting and also gives the evidence base for why we would like authors to include this information. It's not simply a group of people sitting in a room saying, you know, I think you should do this and I think you shouldn't do that. It's what does the evidence, how does the evidence inform us? So it's very evidence-based in its approach whenever possible. So if you want to read a more general history of checklists, Atul Gayawande has written a really lovely little book called the Checklist Manifesto, and it gives a lovely history of checklist development, which started in the mid-30s after a very unfortunate crash of a Boeing aircraft. But it's a very interesting history, and for those of you who are interested in that, the Checklist Manifesto is a great read. So why do I want all of us to use checklists? And it's because they work. And I'm giving you an example in the clinical research domain is the development of a surgical safety checklist, which was developed by Atul Gayawande and a very large team from around the world. And they were wondering whether this checklist had any influence on reducing morbidity and mortality. And what you can see is that really, you know, a very short checklist has profound effects on reducing mortality and morbidity. And I think this is simply one example of, generally speaking, to show you that checklists do work. In the context of using checklists to help improve the completeness of reporting of research, they're definitely a way for authors to remember to report on the design, conduct, and results of their research. And often research is quite complex, and we can forget that happens to us all the time in our daily lives. Checklists can also facilitate critical appraisal of a research report, and I will come to that later on. And checklists, it really puts the authors, the peer reviewers, and editors on a level playing field. There's sort of no mystery about, you know, what do journals want, what do peer reviewers want. It's really out in the open. Use a checklist. All of the information is there as a minimum. And as I've mentioned to you before, whenever possible, you know, checklists are evidence-based. And that's, I think, a very important part of their development. And obviously, checklists can be kept up to date. and in some cases need to be kept up to date as new empirical evidence emerges. So I've said many times this morning that they're evidence-based whenever possible, and it's important to have some key players involved from the beginning of their development, and editors play a very important role here in developing a reporting guideline. I think a face-to-face meeting is very important. It's often where the empirical evidence, surveys, everything is brought to the table to be discussed in person. And there are extensive post-meeting iterations. And then once the checklist or reporting guideline is published, it needs to be responsive to criticism, and it also needs to be evaluated. And all of this we've published, and I won't bore you with any more of that information. You can sort of look and see about attributes of good reporting guidelines. I'm not quite sure why I left that there. I probably meant to delete it. So I'm going to talk a little bit now about some popular guidelines, and I have reporting in parentheses because SPIRIT is a guidance for protocols of randomized trials, and as such, it's really not a reporting guideline. It's much more upstream. It's much more trying to give guidance to researchers who are developing their protocol, and it's much more towards guidance around methods. So SPIRIT is really a guidance to improve the content and quality of a clinical trial protocol. And here's a picture of some of us. I think this is a meeting that was held in Ottawa as part of the development. Here is some of the checklist. You can, I will give you a URL where you can get that information. The checklist includes 33 items in 5 categories. The first category is asking authors about some administrative information. So, for example, item 2A, we're asking trialists to give an identifier and a registry name. And if it's not registered, we're asking them to sort of indicate to us which registry they think they're going to register in. And again, this is sort of best practice. We know that a large number of medical journals will not accept a report of a trial unless it has a registration number. And that is guidance also from the International Committee of Medical Journal Editors. Category number 2 is we're asking for some information about the intended trial. What are the specific objectives or hypotheses that the researchers are proposing? Category number 3 is we're asking researchers to tell us something about the methods they're proposing to use. So, for example, item 14 of the SPIRIT checklist is asking researchers to tell us about the estimated number of participants needed to achieve the study objectives and how it was determined. Category number 4, we're asking researchers about the ethical considerations and dissemination. And category 5 is we're also asking researchers to provide us with some information. So, for example, item 32 of SPIRIT asks about consent forms that are being proposed or that actually have perhaps been approved by a local research ethics board. You can get most of this information from the Spirit website, and I've provided you with the URL. I will mention CONSORT. CONSORT is a guidance for reporting clinical trials. Its latest version is CONSORT 2010, and it includes a 25-item checklist and a flow diagram. For example, in item 3A, we're asking authors to tell us about the trial design that was used. And this is the level of detail that we are asking authors to provide readers. Recent data indicate that authors do not adequately describe interventions used in reports of randomized trials and systematic reviews, and I've not provided you with that information, but there is a substantial amount of evidence to this effect. And we also have some sort of very practical examples of the seriousness of just basic information that is almost hard to believe is missing from reports of randomized trials. Here's a paper by Duff, who really was looking at 10 essential elements about drug information in reports of cancer journals. And what she found is that very few trials actually reported all of this basic information, such as drug name and dose and route of administration. So really, it doesn't matter if a report of a trial is published and it has the most outstanding probability value. If the drug name is missing, it can't be used in practice. Nobody's going to use it. So this basic information is so missing. And in a subsequent editorial, Dancy noted that thoughtful consideration of reporting trial-related procedures that could assist with turning best evidence to best practice would be worthwhile. That's an understatement to me. A careful and consistent reporting would help to promote safe and effective clinical application of oncology therapeutics. Again, an understatement. So we're not asking for, very high-level information. We're really asking for basic information as a minimum. Now, more recently, the Tidier checklist was developed, really getting at how to report interventions in trials. And Tidier can be used in conjunction with CONSORT. You could simply avoid using item 5 in the CONSORT statement, which is about interventions, and use use Tidier. And Tidier really is asking authors to tell readers about the name, basic information, what materials were used, what procedures were used, who was it provided to. So it's sort of, again, basic information that would really facilitate empowering readers about the report that they're using. So I would encourage you to also look at Tidier. Tidier has 12 items that can easily be used in conjunction with the CONSORT checklist. There is a growing CONSORT family, and I will be the first one to tell you that I cannot keep up with what's going on. Not everybody informs me, and I'm not involved in everything, thankfully. But there is a growing family of published CONSORT extensions, and there are other CONSORT extensions that I'm aware of that are in development. Many of these can be found on the CONSORT on the CONSORT website. So I'll talk a little bit now about PRISMA, and PRISMA is related to reporting of systematic reviews, and we've sort of broken it down in much the same way as we have for CONSORT. So PRISMA P is really a guidance for those preparing protocols of systematic reviews. And it was recently published, and I'm sort of really happy to see that there's been a lot of interest in PRISMA P. The PRISMA statement is for those who have completed a systematic review or meta-analysis and want a reporting guidance to help them report it completely. It includes also a flow diagram, and I should have mentioned that CONSORT does include a flow diagram as well. Here are, I've given you the wrong checklists. That's embarrassing. That's the spirit one, but the PRISMA checklist is similar. They all look the same. Item 17, the PRISMA asks authors to report on study selection. We want authors to give numbers of studies screened, assessed for eligibility, and included in the review with reasons for exclusion at each stage. And we think that's ideally done with a flow diagram. Here are a couple of examples from the literature of how that could be done. And again, it's probably not extremely difficult to do, but when it's done, such as these two examples, it really provides an awful lot of clarity about what was included. The rationale for reporting them is, I'm not sure whether the X-Files made it to Ireland. I know they were popular in Ireland, but it's sort of really about when things go missing. And so we're trying to typically avoid situations that I see as an editor. When I read reports of systematic reviews, they say that authors often say, you know, we screened 4,218 records and we've included 6. Well, that's wonderful, but what happened to the other, 4,500? How did you get rid of them, and why did you get rid of them? So it's that information that we're looking for, and it provides some important information about the robustness of the research that the authors are reporting on. There are fewer PRISMA extensions published. There's PRISMA for abstracts, PRISMA for equity, and PRISMA for protocols. In press, I think will appear very shortly, is PRISMA for network meta-analysis and PRISMA for individual patient data meta-analysis. And not far behind is PRISMA for harms. My hope is that we'll be able to bring all of the PRISMA extensions together as a supplement in the journal Systematic Reviews. So I really now want to talk a little bit about the Equator Network, because this is sort of the holy grail of finding information about reporting guidelines. And so Equator has here, it has a library of reporting guidelines. And on its homepage, it has examples of some of the most commonly used reporting guidelines that people are looking for information about. And so you can go to the library and you can find sort of information about reporting guidelines for all different types of studies, different types of data, etc. So I would really encourage you to go to Equator. I'm just looking to see here, yes, I did remember to include the Equator URL, and I would encourage you to go to look there. And beyond the reporting library, they also have toolkits. And these toolkits are really, there's a toolkit, as you see here, for authors. And there's a lot of documentation and a lot of information to help authors write up protocols and write up reports of completed research. And we hope that those toolkits are going to become increasingly more useful and helpful to a very broad range of authors. Issues discussed there are sort of writing articles that are fit for purpose, that are meaningful, that will be understood, and possibly will have an easier time during peer review. Here is the toolkit for authors, and you can see there's a lot of information in there. Time doesn't permit me this morning to go through all of these. I would just encourage you again to go to the Equator Network, spend a little time and having a look at all of these resources. Here is a book for those of you interested. I guess one could say I'm trying to sell my own book, but I'm not getting much money from it. You needn't worry. But here's a book of reporting guidelines. It covers several chapters about some conceptual issues in reporting guidelines, and there are examples of many reporting guidelines. And towards the end of the book, there are a couple of chapters on some practical issues about implementation of reporting guidelines. And I actually think it's cheapest to buy the book through Amazon. So one of the questions I'm always asking is, you know, are we having any effect? I've given you examples of a few reporting guidelines, and certainly referencing the Equator Network, there's well over 200 reporting guidelines. And so the question is, do they have an effect? And I'm going to spend the next sort of few slides looking at that issue. And the way we've sort of conceptualized asking about whether reporting guidelines are effective is we think about it in a sort of a typical PCOS framework. We're looking at published studies. We think the intervention is a reporting guideline, although it's really not the only part of the intervention. The comparator is using no reporting guideline, and the outcome is trying to measure completeness of reporting. And so reporting guideline alone is not the intervention, because the reporting guideline, in a sense, resides almost at a journal, and it's really how the journals endorse it and what requirements they're asking authors. So if a journal doesn't use CONSORT to report a trial, or doesn't ask authors to use CONSORT to report a trial, then it's really not an intervention. So also we know that endorsement reflects the intentions of a journal, and unless it's unless the journal has some way of auditing what they want authors to do, then it's really not an action. So we do know that over time, as